Okay, let's talk about chest pain. It's one of the most common reasons people rush to the emergency room, and for doctors and nurses, it's one of the absolute highest stakes challenges they face. And you want to know why? Because the cause could be anything from a pulled muscle to a life-threatening disaster that's about to happen.
The second a patient comes in with chest pain, a clock starts ticking. The list of what could possibly be wrong is enormous, right? It could be something as simple as acid reflux, or it could be a massive heart attack, or even a tear in your body's biggest artery. So the job isn't just to find the right answer, it's to find the deadliest answers first and fast.
So how on earth do they do it? How do you navigate this maze of possibilities without missing something catastrophic? Well, they don't guess. They use a systematic approach, a kind of diagnostic funnel that's specifically designed to catch the worst-case scenarios first. So let's walk through exactly how that works.
We're going to follow that funnel step by step. First, we'll talk about the challenge itself. Then, the immediate stability check that happens for every single patient. After that, we're going hunting for the most time-sensitive kind of heart attack. From there, we'll cover the other big killers, then the other serious stuff, and finally, we'll see what's left. The whole process is built around one thing: keeping the patient safe.
So here it is, the guiding principle, the absolute golden rule of working up chest pain. You have to focus on ruling out the dangerous stuff before you even let your mind wander to the more harmless causes. It's a rule you just can't afford to break.
And you know what? This whole thing starts before a single fancy test is even ordered. The very first job, the foundation for everything that comes next, is to figure out if the patient is stable right here, right now.
And that brings us to the first practical step in this whole evaluation. It's a little mnemonic that every clinician knows by heart, the ABCDE. Now, this isn't just some boring checklist. It's a super fast, systematic assessment. A is for airway. Is it open? B is for breathing. Are they actually moving air effectively? C is for circulation. You know, what's their blood pressure? What's their heart rate? D is for disability, which is a quick check of their neurologic status. And E is for exposure, which just means you need to get a full look at the patient to see what's going on. If any of these are off, forget diagnosis for a second. The priority is immediate stabilization. Okay, so once the team confirms the patient is stable, or while they're in the process of stabilizing them, the next step happens, and it happens fast. Get an electrocardiogram, an ECG. The goal here is to hunt for one very specific, time-critical diagnosis. We are officially on the lookout for a STEMI. This is the classic big one, heart attack you see in the movies. It means a major artery to the heart is completely blocked, and heart muscle is literally dying by the minute. You've heard the saying, time is muscle, and in this case, every single second counts. The ECG is the fastest way to spot it. Now, what's really fascinating is what they're looking for on that ECG printout. It's a very specific pattern in the heart's electrical signals. But, and this is a big but, it can get tricky. There's another heart condition called a left bundle branch block, or LBBB, that can actually act like a disguise, hiding that classic heart attack pattern. So the rule is, if a patient has all the right symptoms and this new LBBB pattern pops up, you have to treat it like it's a STEMI until you can prove it's not. Okay, so what happens if the ECG comes back and it's not a STEMI? Phew, right? Well, not so fast. We are not out of the woods yet. The hunt continues. Now we have to use the patient's story, a physical exam, and some other tools to rule out the other immediate killers. First up on that list, cardiac tamponade. This is a scary one. It's where fluid builds up in the sac around the heart and literally starts to crush it, preventing it from beating properly. The classic signs are super low blood pressure, bulging neck veins, and heart sounds that are faint or muffled. A quick ultrasound right at the bedside can spot the fluid, and you know you've got it when you see the heart's own chambers collapsing under all that pressure. Next is an aortic dissection. This is a tear in the inner lining of the aorta, you know, the main superhighway for blood leaving your heart. Patients often give a very specific story, a sudden, severe, tearing pain that goes straight through to their back. On exam, a doctor might find the pulses in one arm are way weaker than the other. For a stable patient, a CT scan with contrast dye will light that tear up like a Christmas tree. So, the next killer on our list is a pulmonary embolism, or a PE. That's a blood clot that decides to take a trip up to the lungs. But what's really interesting about this one is that the game plan for diagnosing it is not one size fits all. It completely changes based on how likely the doctor thinks a PE actually is for that specific patient. And here's what that means. If the patient seems low risk, you'll start with a simple blood test called a D-dimer. If that test comes back negative, you can pretty much cross PE off the list. But for a high-risk patient, say someone who just had a big surgery, that D-dimer test just isn't reliable enough. You skip it entirely and go straight to the big guns, a CT scan of the chest to look for the clot. Number 4 on the deadly list is a tension pneumothorax. This is way more than just a collapsed lung. Air gets trapped in the chest cavity and builds up so much pressure that it starts pushing on the heart and blood vessels. The signs are dramatic. Plummeting blood pressure, no breath sounds on one side, and you can even see the windpipe being pushed over. This is one of those times where you do not wait for an x-ray, you see the signs, you make the diagnosis, and you treat it immediately by sticking a needle in the chest to let all that trapped air out. And the final immediate killer is a rare one, but a nasty one, esophageal rupture. A tear in the esophagus means its contents can leak into the chest cavity, which can cause a massive, overwhelming infection. The big clue is often in the patient's story. The pain started right after a session of really forceful vomiting. An x-ray might show air in places it shouldn't be, and a special swallow study where the patient drinks contrast dye will show exactly where the leak is. All right, take a deep breath. We've just systematically ruled out the 5 most immediate, life-threatening killers, but the job still isn't done. Now we move one level down the funnel to investigate other serious conditions that are also a type of heart attack. This whole category is called non-ST elevation acute coronary syndrome, or NSTE-ACS. The best way to think about this is like a traffic jam in the heart's arteries. A STEMI is a complete roadblock. NSTE-ACS is more like the highway is suddenly down to one lane. Blood is still getting through, but it's dangerously slow. This is what we call myocardial ischemia. So how do you tell what's happening within this spectrum? Well, it all comes down to a crucial blood test for a protein called troponin. If that reduced blood flow has already started to cause some permanent damage to the heart muscle, troponin leaks out into the blood, and the test is positive. That's an NSTEMI, a non-ST elevation heart attack. If there's no muscle damage yet, the troponin is normal, and we call that unstable angina. It's a huge warning sign, and since the initial treatment is the same for both, the team can get started before the blood test is even back. It's only now, after we've methodically ruled out a STEMI, the 5 big killers, and the other types of acute coronary syndrome, only now can a doctor safely turn their attention to that huge list of other, less dangerous things that can cause chest pain. And just look at this list. It is incredibly broad. We're talking about everything from inflammation of the heart's lining to lung issues like pneumonia to stomach problems like acid reflux, all the way down to simple chest wall pain and even things like shingles or a panic attack. And this is exactly why that funnel approach is so critical. You have to clear the forest of deadly trees before you can start looking at these smaller shrubs. And that really brings us full circle, doesn't it? The whole point, the entire philosophy behind the chest pain workup is built on a foundation of safety. It's not about finding what's most likely first. It is always, always about finding what's most lethal first. Your job is to make absolutely sure it's not something deadly before you even consider that it might be something harmless. It's such a powerful way of solving a problem, isn't it? Prioritizing safety over everything else. And it kind of makes you think, whether you're an engineer building a bridge or maybe just planning a big project, what other complex puzzles in life are best solved by starting with the worst case scenario and working your way down?